Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Pierre Laumonerie from Paris, France. After completing his medical school in Limoges, France, Dr. Laumonerie completed his orthopedic surgery residency at the Pierre Paul Riquet University Hospital in Toulouse, France. He went on to complete an inter-university diploma of hand surgery at the Institut Laumonerie in Toulouse University Hospital, France. Subsequently, he finished a research fellowship at the Bayer Clinic in Rochester, Minnesota, United States. He has more than 50 peer-reviewed publications to his credit. And if you've noticed, Dr. Laumonerie has delivered several lectures on our channel, and today it's my great honor to bring back Dr. Pierre Laumonerie for this fantastic live program. Over to you, Pierre.
Thank you for this introduction. So good afternoon, everybody, and thank you very much for the invitation. So the elbow is often described as a simple hinge, but it's not. It's a system in balance. And as you said, I'm Pierre Laumonerie, an elbow surgeon based in Paris. And I think that elbow stability relies on a balance between the capsular ligamentous complex, dynamic stabilizers, and joint congruency. And when this balance is lost, instability appears, and reconstruction aims to restore stability. So, to reconstruct properly, we must first understand the anatomy and biomechanics that govern this equilibrium. Everything in elbow surgery starts here. On the lateral side, the lateral collateral ligament originates from the lateral epicondyle and blends distally with the annular ligament without direct radial insertion. The LRCL contributes to varus stability, but only to a limited extent. Primary stability comes from the coronoid and the anterolateral capsule. The LUCL or LCUL, lateral ulnar collateral ligament, originates from the lateral epicondyle and inserts onto the supinator crest of the ulna. It's a primary restraint against posterolateral rotatory instability. And when the LUCL fails, rotatory instability follows. So historically, the lateral collateral complex was described as these two ligaments, the LRCL and the LUCL. But more recently, sorry for this slide. More recently, Adam Watts added a new paper to field the posterolateral ligament. Biomechanically, it appears to reinforce posterolateral rotatory stability, acting as an additional restraint to external rotation and posterior translation. So for now, however, this ligament, so the posterolateral ligament, is not specifically addressed in current reconstructive techniques. Maybe it will begin something important, but actually it's not concerned for the reconstruction. On the anterior side, there is the capsule inserted on the distal humerus and along the anterior margin of the coroid, but it's not concerned in ligament reconstruction except in chronic elbow dislocation. But it's really different. We don't talk about it. So I will not spend too much time about the anterior capsule, just to know it's very important for the varus stability in elbow. On the medial side, the anterior bundle of the UCL originates from the medial epicondyle and inserts onto the sublime tubercle of the ulna. It's the primary restraint to valgus stress, especially between the 30 and 90 degrees of friction. When it fails, valgus instability develops. And this is the main target in medial ligament reconstruction. But the posterior bundle from the medial epicondyle and insert along the posteromedial ulna is also important. It becomes tensioned in deflection and contributes to valgus stability beyond 90 degrees. It also provides posteromedial stability under combined varus and internal rotatory loading, particularly when primary stabilizers are deficient, or in the setting of coronoid loss, for example. Its role remains secondary compared to the anterior bundle, obviously, but it's not because it's a secondary stabilizer. It's not a primary, but it's important too. It can be considered as a tertiary if you consider anterior bundle like anterior band and posterior band and after posterior bundle. So it's a secondary or tertiary stabilizer, but it's a stabilizer and it have to be concerned when you have to stabilize the elbow against valgus instability. So depending on which ligament are injured, you will see different pattern of instability. If we simplify, we can identify three major patterns of instability. The first and simplest pattern is medial elbow instability. It's driven by anterior UCL failure and leads to valgus laxity. In pure varus loading, stability relies primarily on ulno-humeral congruency with secondary support from the capsule near extension. When varus stress is combined with internal rotation, the posteromedial rotatory instability, PMRI pattern, both the posterior bundle of the MCL and the lateral ligament complex are involved. Failure of this restraint, particularly in the setting of coronoid deficiency, leads to progressive posteromedial instability. And after PLRI, the most famous PLRI is driven by LUCL failure, sometimes associated with medial injury. And supination, valgus, and axial load produce external rotation and posterior subluxation. LUCL reconstruction is absolutely essential. And the UCL reconstruction is added when medial insufficiency persists. By the way, in chronic instability, especially after severe elbow dislocation, these three types of instability often coexist. Together, they define what we can call chronic multidirectional instability. It's not unusual, and you can find on patient when you can diagnose big valgus instability and a PLRI. It's not unusual, in fact. But if we stay on severe PLRI, LCL reconstruction is the first line treatment. To address ligament reconstruction, we must consider three main points. The first is graft choice. So the palmaris longus is the well-known. It's the preferred graft for elbow ligament reconstruction due to its availability and low donor site mobility. However, it's absent in some patients and its size can be inconsistent, making it insufficient in combined ligament reconstruction. The peroneus longus or hemiperoneus longus provides reliable size and strength, and it's useful when overgrafts are available. However, it's slightly smaller than the semitendinous. Harvesting carries a risk of common fibular nerve injury. It's not a small complication, and I avoid it in athletes due to the potential effects on ankle stability. It's associated with higher local mobility, including hypoesthesia and neurological complication reported in up to 18% of cases. It's really a graft with a high rate of complication in the site of harvesting. For the triceps tendon is mainly used for the lateral ligament reconstruction or when graft options are limited. It provides adequate strength, but may cause temporary extension weakness and requires extending the incision on the same elbow. And it's less commonly used for medial ligament reconstruction, so it can be complicated if you have a chronic multidirectional instability, for example. And for me, more broadly, there is fundamental contradiction in harvesting a tendon from a key stabilizer of the elbow, like the triceps, to stabilize an already unstable joint. For me, there is a contradiction, and I don't like this kind of predicament. After, for the gracilis or semitendinous, for me, they are robust autograft. They provide biomechanical strength comparable to native ligament. The semitendinous is my preferred graft. Harvesting is minimally invasive and fast, with a consistent diameter and sufficient length for combined LCL and UCL reconstruction when needed. I use it for 90% 90 patient with instability. So I use this ligament for since a lot of time, and for me it's since a long time, and it's a good implant for me. A good graft, sorry. So, however, it requires um, a teeth a rehabilitation for your lower limb and may delay your return to sport in fast track protocol, and it can lead to neuropathic scare pain or hematoma extending to the calf or saphenous nerve sensory deficit. So it's a really good graft, but with morbidity on the seat of harvesting. Allograft, it's the last in my list, but allograft is now my preferred option. Over the past 3 years, we performed around, as I said, 90 elbow ligament reconstruction using hamstring autograft. However, autograft has significant drawbacks and increased operative time due to patient positioning, opening additional trays for tendon harvesting, and the harvest itself takes time. So I'm increasingly treating it, and now in my practice, daily practice, I'm increasingly treating elite athlete. For whom donor seat morbidity has become a real issue. So at the same time, our technical innovation, particularly arthroscopic performed in the lateral decubitus position, have significantly accelerated recovery after ligament reconstruction at the elbow. And in this context, allograft has become absolutely essential for me. However, the downside of allograft is risk of infection, higher cost, and variable availability. So you can work with a peroneus longus a day and another day with a gracilis. It depends on the availability of the allograft. But for me, now I use always the longest extensor for hallux, and it's always the same length, always the same diameter. And for me, it's really easy to planify my surgery. And my surgery are now really more short with short time and more predictable. So I think, in fact, for me, allograft it's more reliable, and we didn't have any infection since in my cohort with allograft. So for me, the allograft is the best choice when you have to do a ligament reconstruction at the elbow, to be clear. The second key issue in ligament reconstruction is the fixation technique. It's a big issue, in fact, because the inlay technique consists of placing the graft inside a bone tunnel, usually secured with interference screws or sutures, and this allows direct tendon to bone healing and provides strong initial fixation with excellent biomechanical stability, for sure. But however, it requires more invasive bone preparation, increases surgical complexity, and carries a risk of tunnel-related complications such as fracture or persistent pain. The only technique involves fixing the graft directly onto the bone surface using anchor and suture, without creating bone tunnels. This approach preserves bone stock and reduces surgical invasiveness, in fact. It's a big point, big element, and it's our preferred option because it's not only bone sparing, but it's also muscle, capsule, and ligament sparing. And it also simplifies combined ligament reconstruction and significantly shortens operative time. It's a real game changer for me. And the third key question is whether we should reconstruct the ligament anatomically or not. Isometric graft positioning aims to maintain stable tension across the range of motion, avoiding over tightening or slackening, as demonstrated by Murray and Ann in the GBGS in 1983, and later by Calloway and colleagues in GBGS in 1997. But Dunning also in the GBGS show that non-isometric tunnel placement can lead to significant graft length changes during motion, resulting in laxity and or excessive tension. However, clinical studies by Ahmad in 2003 and by Kemp's 15 years later reported similar return to spurt rates between techniques such as job or docking fixation. So while isometry clearly optimizes biomechanics, moderate non-isometry does not necessarily compromise midterm clinical outcome. So we were very strict, very focused on biomechanics at the beginning of the 20th century. And now we are really less focused on it. And I think it's a good way. We have to see the emergence of non-anatomic stabilization techniques such as Van Ritz, arthroscopic LCL imbrication with PDS loop for low-grade PLRI or box loop reconstructs. They are absolutely not anatomic. They are not anatomic, and yet they work. So their strength lies in simplicity, speed, and tissue preservation, sparring. And I really like this modern approach, and for me, the future is here. So when we know that muscle sparing approaches have been associated with post-operative stiffness rates below 10% in minimally invasive series, compared with rates approaching 20% after more extensive open procedure. So as reported in GSES or and arthroscopic journal in the early 2000s. So preserving sparing muscle and preserving a capsular ligamentous balance matters more than achieving perfect isometry and exact anatomic reconstruction. It's the main message of my slide. Preserving muscle and capsular ligamentous balance matter is the most important element when you have to do a ligament reconstruction. So at the beginning, there was job techniques for the UCL, and after docking. Docking is a ligament reconstruction technique inlay for the elbow, first described in 2002, where the graft is docked into humeral tunnel and fixed on the ulna, allowing precise graft tensioning. Ligament reconstruction started with Job's first procedure in 1974 and has evolved through several key steps aimed to reducing nerve complication for the MCL, for the UCL reconstruction, and also improving outcomes, of course. Docking reflects this shift toward more tissue preservation approaches compared to earlier figure of 8 techniques. This is the 8 techniques, for example. But all these techniques are inlay, and they still rely on bone tunnel and often autograft with donor site morbidity, risk of ulnar nerve irritation for the MCL, and tunnel-related complication, as fracture, for example. For me, it relies also for a longer operative time and no clear superiority over more recent technique. We changed a little bit the technique, so it improved a little bit, but there are no game changers since a lot of time. Since a lot of time. So recent uncontinuous sparing docking variants aim to improve soft tissue preservation, but their benefit remains to be clearly established. Because it's not really a game changer, it's always the same technique and it's an invasive technique for me. So in this context, we introduce a mini-invasive technique, which adds bone sparing since we avoid bone tunnels. The goal is simple: stabilize the elbow without compromise muscular balance. We are moving toward augmentation rather than full reconstruction, in fact. But I use this technique, not minimal invasive, but I use this kind of fixation on chronic elbow dislocation too. So we can use it with less sparing, but this kind of fixation is reliable. And this concept already adopted in oversions such as lateral ankle ligament bracing or extra-articular augmentation in ACL surgery is a robust model. And I will show you this minimal invasive for the first time. It's a step-by-step technique, and I will let you watch this technique.
In this video, we present our minimally invasive LUCL reconstruction using a prosthesis graft. The lateral humeral column, lateral epicondyle, and radial head are marked. 1 cm longitudinal incision is made at the most distal part of the lateral column, above the epicondylar tendons and just medial to the lateral epicondyle. Oman retractor are placed anteriorly and posteriorly along the distal humerus to improve the exposure. The guide is located at the most distal part of the lateral humeral column and proximal to the anterior capsular insertion. It's very important to keep the guide perpendicular to the anterior cortex. An oblique drilling trajectory may lead to reduced anchor stability. And then a fiber technoless anchor is inserted bicortically into the posterior cortex of the humerus. The suture from the FiberTech anchor is then inserted into a shuttle loop. Pulling on the loop draws the suture into the anchor and locks it automatically, creating a knotless lasso effect. Fluoroscopy is then used to obtain a strict lateral view of the elbow. The distal insertion is located below the supinator crest and distal to the proximal edge of the radial head. It's important to keep the guide perpendicular to the lateral cortex of the ulna. An oblique drilling trajectory may lead to reduced anchor stability. A second FiberTech anchor is then placed bicortically at this location. The suture from the second FiberTech anchor is inserted into a shuttle loop. Pulling on the loop draws the suture into the anchor and locks it automatically, creating the knotless lasso effect. A Kelly clamp is inserted between the capsular ligamentous plane and the lateral epicondylar tendons to create a tunnel connecting the humeral and ulnar anchors. Passing suture is then passed through this tunnel, and the graft is then pulled through the tunnel using the passing suture. Once the graft has been passed, this later is then inserted into the two created lasso. The proximal and distal edge of the graft should exceed about 3 cm. Traction is applied along the axis of the anchor, perpendicular to the lateral column of the ulna, ensuring firm fixation of its graft against the cortex. The elbow is then placed at 60 degrees of flexion, taking care to avoid varus. Then a strong traction is applied along the graft axis, and the lasso is locked by pulling perpendicular to the cortex of the humerus. All sutures are cut, and the graft ends are trimmed, leaving about 1 cm beyond the locking point. The LUCL is reconstructed through 2 incisions of 1 cm in length. Post-operative cares follow the fix-it-move-it principles: no immobilization, immediate active motion, immediate stretching and strengthening of the lateral epicondylar and triceps muscles. Shoulder forward elevation and abduction are limited for 3 weeks to prevent gravity-induced varus stress. Return to life.
So this video has been accepted in arthroscopy techniques. You can see blood sometimes because we did UCL and LCL reconstruction for this patient, so you can see blood. But if you are doing only LCL, there is any blood. It's very small, very small incision, so It's minimal invasive and you have no blood. We will soon submit our series of ligament LCL reconstruction by minimal invasive approach, and we will share our results. So to highlight our post-operative guidelines, 2 points very important. Return to light sport. So light sport is running and kind of things like that. It's is allowed at 6 weeks. And return to high demand activities at 2 or 3 months. It depends on the sport. But for patient, we can start again box, MMA, we can start judo, we can start all we want at 2 or 3 months. If all is okay, obviously but it's really we start really after a short delay after surgery. So without going into details today, our actually submitted series suggests that this technique likely speeds up recovery of functional range of motion and return to sport with low postoperative pain. The full data will be available soon, and you will be able to see the complete result in details. That's the result for the minimal invasive. But now, for patients with exclusively LCL reconstruction, we are doing only arthroscopy approach. By arthroscopy, we are doing exactly the same technique, but only by arthroscopy, and we increase again the delay for recovery functional range of motion and return to sport. It's it's faster than the minimal invasive. So less invasive equal faster rehabilitation. There is clearly a link and a significant link with odds ratio very high. So now regarding the medial collateral ligament reconstruction, usually we say when we have the UCL reconstruction, it's harder because it induces more stiffness and it's more difficult. It's more difficult because all the techniques are very invasive. But for UCL reconstruction, it's exactly the same principles. The MCL and UCL, sorry, is mainly responsible for valgus stability and stability for if it's injured, and it may also be involved in PRI, because in PRI, when it's a dislocation, you can have both LCL and UCL involved. So when valgus laxity and chronic rotatory instability coexist and are both clinically significant, I describe this pattern as a chronic multidirectional instability. I talked about it in the previous slides, which requires combined LCL and UCL reconstruction. So when you have a technique, you have to be as fast as you can, because sometimes you have to do both sides of your elbow, so you have to be fast. And this technique is interesting because it's fast, so you can reconstruct both sides in less than 1 hour and a half. So UCL reconstruction raises the same challenge as LCL reconstruction, graft, fixation, anatomic, but you have a key difference, which is that the UCL has 2 bundles. The entire bundle restores valgus stability, but in combined rotatory or various patterns, especially in chronic multidirectional instability, the posterior bundle must also be addressed. And it's a very important point for me. So here again, I'm going to show you step by step the video of our minimally invasive only technique for UCL reconstruction. Here again, this video has been accepted in arthroscopy technique, and we will soon submit our series of ligament UCL reconstruction by this technique. So,
in this video, we present our minimally invasive UCL reconstruction using aggressive graft. The incision is made along the course of the ulnar nerve. The fascia is assessed, a neuralization of the ulnar nerve is performed, and the nerve is looped. The elbow is then flexed to 120 degrees. An incision is made just above the epicondylar tendons. The guide is located at the most distal part of the medial humeral column and proximal to the anterior capsular insertion. A fiber technoles is inserted bicortically into the posterior cortex of the humerus. It's very important to keep the guide perpendicular to the anterior cortex. An oblique driving trajectory may lead to reduced anchor stability. Fluoroscopy is used to obtain a strict lateral view of the elbow. For the anterior bundle, the distal insertion is located just below the sublime tubercle under fluoroscopic guidance. A fiber technoles anchor is placed endomedullary in the ulna. It's crucial not to breach the lateral cortex to avoid conflict with the radial head. The anchor must be inserted perpendicular to the cortex to ensure solid fixation. The space between the capsular ligamentous plane and the medial epicondylar tendons is dissected to create a tunnel connecting the humeral and ulnar anchors. The graft is then passed through this tunnel and then under the ulnar nerve. Once the graft has been passed, the suture from the humeral fiber take anchor is inserted into a shuttle loop. Pulling on the loop draws the suture into the anchors and locks it automatically, creating a knotless lasso effect. The graft is inserted into the created lasso. The proximal and distal ends should exceed about 5 centimeters. Traction is applied along the axis of the anchor, perpendicular to the medial column of the humerus, ensuring firm fixation of this graft against the cortex. The same procedure is performed for the ulnar anchor to create another lasso. The graft is then inserted into this created lasso, and the elbow is fixed at 60 degrees of flexion, taking care to avoid valgus. Then a strong traction is applied along the graft axis, and the lasso is locked by pulling perpendicular to the cortex. The elbow is then flexed to 120 degrees. A third fiber technoles anchor is inserted bicortically into the lateral cortex of the ulna and vertically aligned to the medial epicondyle line. At this level, there is no risk of radial head impingement. A Achilles clamp is placed beneath the capsular ligamentous plane and under the epicondylar tendons to retrieve the proximal graft end. This proximal graft is passed under these tendons and then under the ulnar nerve. A new knotless lasso is created by passing the suture through the shuttle loop of the fiber take anchor. Traction must be applied perpendicular to the axis of the ulna to create the third lasso. The graft is passed into the lasso and tension to lock the fixation. All anchor structures are cut. The grafts are trimmed, leaving about 1 centimeter beyond the locking point. Both anterior and posterior bundles are reconstructed through an incision of about 2 or 3 centimeters. Post-operative care follow the fixed movement principles: no immobilization, early active mobilization, immediate strengthening of the flexor-pronator mass, and avoidance of passive mobilization. Return to life path is a low at 6 weeks. Return to high demand activities at 3 months.
So, as you see, compared with docking or modified job techniques, this new approach has allowed a much faster return to function with return to sport in less than 3 months. In fact, in our daily activity, the patient have a full range of motion in less than 2 weeks if there is no other things, if there is no a big arthrolysis and resection and a big associated lesion. But for only ligament reconstruction, the random patient has a full range of motion in less than 2 weeks. And for the LCL, it's in less than 1 week. And by arthroscopy, a day after or 2 days after they have full range of motion. So it's really, really fast. It's an absolute game changer if we are focused on a return to sport or return to a functional range of motion. And I operate on many combat athletes, and some have resumed international competition at 3 months. So the main limiting factor in this technique was the gracilis harvesting, which caused pain in their lower limb and delayed return to sport. It was the main limiting factor. It's for this reason now we use allograft, and we expect that we're gonna reduce this period of return, this delay to return to sport. We will be submitting our series in the coming weeks with both lateral and medial side. And finally, based on my experience with around all techniques, more than 100 elbow ligament reconstruction, the management of complex instability cases, I identified three main groups. Sorry. The first, in this distinct form, in these three distinct forms, we can. Sorry, I lose my slide. I just have to come back. We have three distinct forms of dislocation in the context of chronic instability. And in this chronic instability with both LCL and MCL involved, all that are into one pattern, and this pattern is the chronic multidirectional instability. And in this chronic multidirectional elbow instability, we have three forms. So in this three forms, the first group experienced a single dislocation and later developed a persistent instability without further true dislocation. The second group had recurrent dislocation, sometimes up to 15 episodes. These were typically athletes presenting with chronic multidirectional instability after repeated injuries, and this patient with bony dysplasia or connective tissue disorder were excluded. And the first group, the unreduced, consists of chronic unreduced fixed dislocation. Interestingly, these patients were often only moderately painful and retained a residual arc of motion. They are not fixed, they can move a little bit, about 30 to 40 degrees sometimes, and which explains why they sometimes presented several months after the initial injury. We operate the patient with a chronic elbow dislocation for 5 years. So it can happen because we have a residual range of motion. So for me, recurrent dislocation represent multidirectional instability. Biomechanically, it's unrealistic to think that an elbow can be dislocated repeatedly without combined injury of the LCL and of the MCL. If you have a repeated dislocation of the elbow, you have an injury of your both side of your elbow. That's why I usually propose triple ligament reconstruction addressing the LCL and both the anterior and posterior bundles of the MCL to restore overall balance. And another option could be isolated LCL reconstruction when valgus instability is mild, and when valgus instability is mild, restoring the LCL alone may prevent a redislocation as it acts as a ligamentous buttress. However, I find this approach insufficient in athletes exposed to high valgus stress, such as combat sport athletes, for example. And for all these patients, I prefer to construct UCL and LUCL with anterior and posterior of the MCL. MCL or UCL is the same thing. After, in case of a single dislocation, isolated reconstruction of the LCL or the MCL can be appropriate. However, in severe pylori, for example, with a clear valgus instability, I also recommend reconstructing the MCL in addition to the LCL, especially in athletes with valgus strain. So it's the same thing. It's not because it's recurrent, it's only one dislocation, but with damage on the both sides. And I think LUCL is not enough if you are an athlete or a young patient with strain, valgus strain. And finally, for the last group, in chronic dislocation, the key issue is to assess bone and articular destruction because it's a chronic dislocation. And in case of major coronoid height loss, for example, or significant deformity of the olecranon or trachea, reduction can be extremely difficult and sometimes absolutely impossible. And in this case, total elbow arthroplasty may be required. But for the all other case, the French elbow connection can be indicated. We treated a series of 12 cases with what we called the French elbow connection, published in International Orthopedics in 2025. And this technique consisted of a complete and extra-articular release followed by reconstruction of the LCL and both anterior and posterior bundles of the MCL. We systematically added anterior capsule repair. That's why I explained it in the first slides of this presentation. To repair, we repair the anterior capsule to the chronoid using an anchor to better control the varus in extension. And 2 years ago, we were using a job style bone tunnel because it was my first technique. And now we prefer extra anatomic and only fixation. So it's exactly the same thing for minimal invasive, but with a very invasive approach. And of course, so it's an extensive arthrodesis requires a significant open approach. It's not a minimal invasive. We also transition from grafts autograft to allograft because it's a big surgery, a big process for chronic elbow dislocation. So we don't want to lose time to have an harvesting, and so it's really faster, and it's an important point too. So we're gonna finish on this point. Thank you a lot for all. For me, in the past, elbow ligament reconstruction was invasive, heavy, and associated with slow return to sport. Minimally invasive and arthroscopic technique have changed the game. It's the main point, and less obsession with perfect anatomy and isometry for more invasive on tissue, more emphasis on tissue sparing. So now faster, safer, more efficient recovery are the main words of this presentation. Thank you for your attention.
Thank you, Pierre. Pierre, you can stop sharing. Thank you, Pierre, for this wonderful presentation, and congratulations for the papers that you've published on this topic.
Thank you. Thank you a lot.
Yeah, Pierre, just a few questions. It has been a long presentation, so I'll keep it short. Have you encountered ulnar nerve neuropraxia when you do your medial collateral ligament, medial side ligament reconstruction?
Yeah. Ulnar transient only, transient, it's okay, transient, not chronic ulnar neuropathy, just transient for 2 weeks, 3 weeks, or sometimes 1 month, but after it decreases and they have no persistent ulnar nerve paresthesia. But you can have paresthesia, neuropraxia of your ulnar nerve, but it's very important to have a good release of your nerve. It's the first time of this procedure. You have to be very meticulous with it and to carefully release your nerve to pass your graft under the nerve. But if you do it with very carefully, there is absolutely no problem with it.
You need to pass the graft under the nerve, right?
If you pass the graft over the nerve, you can have some problems. Yes, obviously, we pass the graft under the pronator mass and under the nerve in the same times. You have to be very meticulous about it. And for me, it's better to do in the same times because if you are doing on the muscle and you say, yes, I will do it after on the nerve, it's weird, but you can forget it and put your ligament on the nerve. You can forget it, but it's terrible if you are doing it. For ulnar nerve neuroplasia, we have around 2 or 3 patients with it, and it's transient. So it's really not a problem with this technique. Absolutely not.
And Pierre, you said on the lateral side, the angle that you use, it's 60-degree, right? That is the angle you fix the graft, the
Yeah,
isometric point. What about the
yeah.
medial side? What is the angle?
Interesting question. For the first time, for the lateral side, I said 60 degrees because I used to do it like that. But there is no biomechanical justification of it because for the LCL, it's just a reconstruction for a rotatory instability. So we don't care if we are in extension or in flexion. But I prefer to be in 60 degrees. Now I'm doing it by arthroscopy and I'm closer to 90 degrees. I just open a little bit to fix it, but I don't care on the LCL approach. For the MCL, I'm around 60. I'm around 65, 70 for the posterior bundle, and I'm around 55, 50 for the anterior bundle. But the landmarks is around 62. It's, it's very important. Don't fix your anterior bundle of the MCL at 90 degrees because if you strain a lot of your graft and you fix it at 90 degrees, you can induce a big stiffness. I think. I never test it, but I think it's a little bit dangerous. 60, for me, it's simple. It's a simple landmark, and you can fix both anterior and posterior bundle with it around.
Pierre, thank you. I think that's all the questions that we have for this session. Thank you for the wonderful talk. And it's a great archive, the videos. I mean, someone who wants to do the lateral side procedure or the medial side procedure, this is going to be a great archive. They can watch it anywhere, anytime, all over the world.